Let me begin by welcoming everybody here this afternoon to hear a really special speaker. As those who visit our website for the PrEP program know, periodically we bring in national, if not internationally known, leaders in the field of pain to speak about their work, because nothing compares with seeing the person who's done the work face to face. Beth has done so much work in so many areas of pain and has so much to talk about that while I could give a very, very long introduction, it wouldn't be fair to her because she has a lot to speak about. So let me just speak for 30 seconds about some of the high points. Beth is a graduate of Johns Hopkins, and she is a specialist in neurology. In addition to having an MD degree, she also earned a PhD degree and has dozens of publications looking at pain in its cellular and in particular ion channel level. But as Beth progressed further in her clinical work and work as an educator at Hopkins, she became interested in introducing pain into the medical student curriculum. She has approached this in a very thorough way by first publishing a landmark survey of how much content about pain and of what form is taught in medical schools in the US, and she'll present on that. She's also published a consensus survey through a Delphi method about where the pain curriculum should go in the future, and has been an active participant in the Mayday project led by Scott Fishman, who was another speaker in this series, about interprofessional competencies for pain management. She has herself been a Mayday Fellow and has received many awards and honors for her remarkable productivity and innovation. So I'm going to stop there because I could speak for much longer, and it would only be at the expense of her talk. So why don't you come on up?
Thank you, Dan, for the lovely introduction and for the opportunity to be here today and to meet with faculty and students here at the Tufts University and the PrEP program. It's a real thrill for me to come and meet with people who are excited about medical education and pain education and interprofessional education. And I'm going to talk a little bit about some of the ideas that we've been working on, some of the ideas that people have been working on nationally. And if anyone has questions about IASP and some of the work that's been done internationally, I'm happy to address those at the end. So I'll start with some disclosures with tongue firmly planted in cheek, because we all know that people don't make lots of money off of education. And I think this is one of the big challenges in the field, is that people pour so much of their heart and soul into their educational products that they almost come away feeling like, well, I should be able to get something out of this. And one thing for sure, those of us who are engaged in writing academic textbooks, those are rarely money-making endeavors. I did receive a small advance from my my mainstream publication, which is called Take Back Your Back. And that book was intended to foster conversations, meaningful conversations between patients and their providers, because I certainly had the experience that most of my medical colleagues didn't get much education about back pain in medical school. And you'll see that our study, which was not really motivated by this issue, did find that. But certainly we know that unless you went to an osteopathic medical school, you might have received 1, 2, 3 hours about spine pain in total, and yet it's the #1 cause of work-related disability. I wanted to start off by showing by example kind of how we could think about problems in terms of, that is to say, educational problems in terms of sort of cognitive learning challenges, skill-oriented learning challenges, and affective or social-emotional learning challenges. And so these learning objectives are written from that standpoint. So for starters, there's so much that I would like to convey to each one of you about the knowledge surrounding pain education in the United States today. And certainly that plays into both the clear gaps, which I'm going to talk a little bit about, the diverse components of physician competence, and the distinctions between curriculum content and competencies, which have been very popular. Thank you. And are important to kind of understand those terms so that you can use them effectively and construct your educational program in a way that is meaningful and yet also professional. Then from a skills standpoint, I'd like each of you to come away with the capacity to do certain things after hearing this presentation today. So what are those things, or what might those things be? Be able to describe major challenges in the development of pain curricula. Be able to describe the contributions of expertise, skillfulness, and what I've termed for this talk, comportment, in a rationally developed pain education program. And I'm going to introduce that concept of rational curriculum development later on in the talk. And I'd like you to be able to talk afterwards about, give a balanced appraisal with your own unique perspectives in terms of what are these things that we have. We have content, we have curriculum, we have competencies. And one of the major controversies raging right now is which of these is most important, and how do we balance the effort and resources that go into the development of these different component parts. And then certainly, because of my interest in social emotional development, I have certain motivational or affective goals that I'd like each of you to come away from this talk today. And those include being excited about the potential for pain education to transform healthcare practice, right? We know that there's a lot that we need to instantiate to our learners in order to get this right. We have a lot of people who are walking around right now with undertreated pain, and we have people who are walking out of clinics this moment with too many opioids. And so we have these kind of twin dangers of chronic and even multiple occurrences of acute pain at the same time that we have inappropriately treated pain, and education is clearly the solution to that. I can accept that you may be dismayed by the scope of the problem, because when we face the fact that, and I'll show this later, that we have so much need and we have so little actually happening, it is a huge gap and can be dismaying. But I hope that each of you will leave here committed and better prepared to take on the status quo and to make substantive changes here at Tufts and wherever you happen to go. All right, so one of the questions that comes up is, why is social emotional development important? And why did I choose the word comportment for this presentation? And so this is just, we did a seminar for several years in pain in the humanities, and this is one of the image pairs that I came across in art store. The upper left is a Caravaggio, a very well-known, somewhat dark and rather troubled painter from the Renaissance, who these dental paintings were very popular at the time. They have a lot of drama. And certainly when you compare and contrast the Caravaggio on the left to the von Honthorst on the right, you see a very different affective content. Is there anyone in the audience who would like to just volunteer something about what they see in terms of the affective content of the image? Compare the Caravaggio and the von Honthorst.
The clinician on the lower one is looking at the patient. They've got eye contact. He's smiling. The one is coming up like he's about ready to slit his throat in the Caravaggio.
Great. So I'm just going to repeat that so that everybody can hear. So the clinician on the lower right-hand side is gazing at the patient. He's giving eye contact. He's in a supportive stance. And the patient on the upper left looks like he's going to slit his throat. He looks a little demonic in character. And so you could certainly see that experiencing pain in the context on the left side would be a very threatening, amplified experience, whereas the pain, the contextual clues, as Hippocrates says, you must be prepared to compel the attendants, meaning the peripherals, those who are associated with the clinical encounter, need to also be in a supportive stance. And that takes a high degree of motivation and an appropriate sense of what the patient's needs are. So that's why we look at affect and social emotional development in the pain encounter, because it has such a huge influence in the outcomes, measurable and otherwise. So I'd like to take a step back and talk about a study that we did. This was published in 2011. It has become a cornerstone of the impetus to increase pain education in the United States, and certainly very delighted about that. And I just wanted to share a little bit about the study with the audience. So what we did is we were frustrated by the fact that what was known about pain education at the medical schools in North America was very limited. It was essentially at the time of our study limited to the fact that the AAMC had a list of 20 some odd hot topics that had asked medical schools to check off whether they were included in the medical school curriculum or not. And certainly that's one measure. It's a very crude stick that says, is there pain or not? And we certainly would hope that that would have a 100% response rate. But what we wanted to do was to take a little more careful look. And so we actually had a pain curriculum development team, which was our institutional leaders. It was an interprofessional group from the very beginning. We had nursing, we had a basic scientist, we had a clinical psychologist, we had an internist, we had an interventional person. So we had an interdisciplinary team, an interprofessional team from the very beginning. We devised a series. It turned out to be 255 learning objectives for our students over the 4 years of medical school. And that instrument then, that actually was informed by the existing curricula and literature from ISP and from boarding organizations. But these learning objectives was eventually turned into an instrument to evaluate pain curriculum worldwide. Now, we were greatly advantaged by the fact that there are very few synonyms for the word pain. In the English language, pain does get used to describe various forms of pain, but we don't have other words that really substitute in for that. So what we did is we went to the AAMC database. We searched for pain. We also searched for some other related topics. And a school had to have a certain degree of participation in the AAMC database in order for us to consider them a study participant. They didn't have to consent because it was a database search, and that the IRB actually reviewed our study for an exemption. In any case, what we found is that the red arrow here is showing the modal number of pain education hours in US medical schools, and that number was 4. So the most common number of hours taught by medical schools in the United States was 4. So over 4 years, it's 1 hour a year. So this is showing on the expanded scale the hours from 0 to 10. And then you can see on a more condensed scale in the black bars the US hours. And then in gray, the AAMC database also included the Canadian schools. And this actually became a very important form of external validation for our study because Judy Watt-Watson and colleagues had studied this in Canada. And so because of the technique that we used, we were actually able to see in some detail the representation of various topics in medical school curricula. And what you can see here is that we had a total number of 117 out of the 147 or so medical schools at the time that we deemed to be participants. They were actively participating in the Comportment database. And what you can see is that of all these, this is just a selection of important topics in pain, including NSAIDs, opioids, examination of the back, and there's no single topic that is represented at the majority of US medical schools and accounted for in the Comportment database. So this is what we concluded at the end of our study. Pain is a huge part of clinical medicine, which is represented here in these bars. We know from Medicare and Medicaid studies that something between 30 and 50% of clinical encounters involve some pain, right? Your clinician needs to hear about pain, understand it, and maybe include it in the treatment plan. And this little red square over here actually represents the amount of time in medical school that's devoted to pain. Now, you may say pain is not the be-all and end-all in every clinical encounter, but when you come with pain, you certainly expect your clinician to be able to offer some competent form of assessment and treatment. Unfortunately, we don't have similar data for the other health professions at this time in the United States, and I think that hopefully will be a major priority after the National Pain Strategy rolls out. But Judy Watt-Watson and colleagues have done this study in Canada where the number of health profession schools is admittedly smaller. They used a distinctive methodology of direct survey to the school. But what they found is really intriguing here, and I'd like to highlight the following. That in Canadian medical schools, they concluded that the average hours were 16, comparable, not identical, but comparable to our findings. Nursing schools averaged 31 hours, and here's the punchline that everybody loves. If you're a dog, you will get better care than you will if you're a person. Because veterinary medicine schools actually offer 87 hours of pain content. So that just goes to show we humans have a long way to go. So I'd like to roll this back to the idea of how do we define clinical competence. And a landmark article by Epstein and Hundert in JAMA in 2003, I think, has provided a foundation for a lot of us in medical education. And in that article, they identified the 7 domains shown here. So certainly, it's not a stretch to appreciate that pain impacts all of these domains. It impacts clinical knowledge, reasoning, emotion, technical skills, values, reflection, and communication. So, but this is a pretty complex problem, right? We've got 7 domains swirling around, and then we've got pain, which is sometimes a little hard to get our hands on. So coming from the pain world, where the ISP says pain is an unpleasant sensory discriminative and affective experience, right? Or maybe an unpleasant experience with, so in any case, there are clearly sensory discriminative and affective domains that are ascribed to pain, and that's now been validated by tons of studies, including functional MRI. But affect and cognition are no strangers to the pain provider and the pain researcher. So we wanted to think about our educational challenges in terms of knowledge, affect, and also we brought in reflection. If you remember the Epstein and Hundert paradigm, reflection is part of their paradigm, and certainly a lot of us who have been in clinical medicine for more than a few years appreciate the value of reflective practice. So we set out to evaluate these in our students. So we started by reviewing the literature, and what you can see here is there's a very strong linkage between cognitive expertise, its impact on the patient-clinician interaction, and clinical outcomes. That is a well-determined pathway. Emotional preparation and the involvement of affect in a successful clinical encounter is a little bit softer, but there is an evolving, accruing body of knowledge, especially in the area of the chronic disease model. And I think a lot of us working in chronic pain think that the chronic disease model is a wonderful linkage between the broader world of medicine and the somewhat smaller world of pain medicine, because the techniques that we use in managing chronic pain are the same ones that regular internists and endocrinologists are talking about in a chronic pain setting. The linkage between reflective practice and clinical outcomes is a little bit softer, but certainly there is some literature that's starting to come out that says that if you are a reflective, compassionate person, you have a lower likelihood of burnout. And so all of those feelings that we have sometimes thinking, I need to pull back, I need to protect myself, I need to not give as much to this patient. The studies, certainly from the palliative care literature, suggest that if you are open, compassionate, and willing to expose yourself to those feelings that patients have, both the highs and the lows, that your chances of burnout will be lower. I think it's a promising start, but a lot more needs to be done. So the idea of thinking about a clinical encounter and the developmental challenges of a clinical encounter as a cognitive affective model actually has very good face validity for pain-focused care. As I've already said, in the pain world, we think about pain as having this sensory discriminative / cognitive part of the cortex. As a neurologist, I tend to think in these terms, so if anybody has questions, please don't hesitate to stop me. And then also the representation in the limbic, or the affective part of the cortex. And certainly when we talk to patients, we are, in all likelihood, I don't know that anybody's done twin MRI studies yet, but certainly the empathy studies suggest that we're activating those parts of our brain. So, but there's an issue, and one of the issues is that when we come to medicine or nursing or pharmacy, or when we're starting our health professions career, we do not have the cognitive substrate to understand what patients are telling us. I've had this experience when I have a medical student come to my clinic and the student's never heard of small fiber neuropathy, or if they heard of it, maybe they were sleeping. So small fiber neuropathy, if you don't know what it is a really strange bird, right? There's almost no exam findings. It is bizarrely painful, bizarrely troubling. It's a challenging scenario, and the patients talk about it a lot, and they feel stigmatized, and NSAIDs don't work, and Tylenol doesn't work, and even the opioids aren't that effective. So it's an unusual syndrome, and the patient is trying to tell the student something, and the student can't quite make out what this is. So The fact is, when we start our health professions, experience, all of us have an underdeveloped cognitive framework to understand what the patient is trying to convey to us. Nonetheless, all of us are relatively developed as human beings, right? We come to this career in early adulthood, and we have this affective substrate, and we can definitely get the cues. We understand that this person is frustrated, sad, alienated. There's a whole lot of stuff going on in that encounter that comes through loud and clear, and sometimes the emotional or affective channel is overloaded. Once you begin to learn how to talk to patients and ask the right questions and get that diagnostic information, even with your basic clinical skills training, you can start to unload that affective channel, because at least the patient feels like, gosh, somebody finally listened to me. Somebody finally asked me a question. Somebody finally said to me, do your feet burn at night? Well, yeah, they do. You must really understand what's going on with me. And so you can, by virtue of developing your cognitive framework, you can begin to offload some of that affective overload. But in fact, you actually need emotional skills training to understand what it's like to be a patient, what a patient needs, how you can get the system to provide people with the support that they really need to deal with the challenges that they have. And we wrote about this model, and actually there's a fourth stage to the model, which is the process of developing reflective practice, which is that moment when all of us go away from the hospital and we're thinking about, what could I have done better today? What could I have done differently? Or gosh, I really got through to that patient. I had a patient on Tuesday who came in tremendously anxious, and it came out that she wanted to know her MRI result. Now, she knew she'd had a small stroke previously, but she was so happy when I told her that her brain looked really good. Except for that little stroke that she had, she didn't have a touch of atrophy. There was no white matter disease. And she felt so good. And I felt good because it's like, wow, I really connected with her and I got to what she needed to hear. So we can celebrate the victories. We can work on what we need to keep doing better. So we wanted to know, as I've been kind of building up to, we've got this cognitive part and this affective part and then reflections over here. And so we did a series of surveys with the Hopkins medical students where over 3 years we gave them a series of clinical vignettes. We asked them to rate the pain being described in the vignette. Now this was really straightforward because the patient said the pain in the report of the vignette. And all they really needed to do was move that number over to the box. But there's this systemic process of pain underestimation, and there's a whole literature about pain underestimation. But we wanted to try to see, is there cognitive influence? Is there affective influence? Does reflectiveness influence this? And what we found, and we reported this at IASP, that the negative emotions endorsed by a student in response to a pain patient were the sole variable in our study that had a predictive impact on pain scores. And what we could see is that the more negative emotions that were endorsed by a student in response to pain, the lower their pain estimate was for the clinical vignettes. And so that then becomes an interesting interplay between what is a kind of a little bit of a hothouse version of clinical decision making, rating pain, and your affective response to a symptom. And we also found, so let's talk about external validity, we also found that the students' ratings of themselves as empathetic towards these patients went down. We had the opportunity to work with MS1s, MS2s, and MS3s, and what we saw is that the MS3s and MS2s had higher cognitive or clinical knowledge scores, but the MS3s rated themselves as lower in terms of being empathetic towards the patient. That didn't necessarily impact their accuracy, and we actually think there's a certain clinical skillfulness that develops in terms of accepting the pain score, right? You get in the clinic and you hear it enough. This is a pain score. The pain score is what the patient says it is, and that begins to sink in. So we actually dug in a little bit deeper and looked in more detail at emotional development. And there's certainly a literature on what's called EI, right? I mean, that was all the rage in the, mid-80s, early 90s, emotional intelligence, your EQ. But you can actually parse out emotional intelligence into sort of a little more specific detail. So looking at the literature and looking at our students, we decided to adopt the following framework, which is to break it down into emotional strength, emotional intelligence, specifically, emotional resilience, and emotional regulation. I'm going to talk about each of those components now. So emotional strength is comprised of things like empathy, things like compassion, which is distinguished from empathy as being, sort of that vicarious appreciation of the suffering in another, but then coupled with the response to help, right? Empathy is you sit in your chair and you feel really bad, but you don't do anything. Compassion is where you actually get up and you go and you do what's needed to help the person who's suffering. And then capacity, because there are those people who simply seem, inured to the emotions of others. They just don't seem to, get it. And I'm not gonna, give examples, but we know who those people are. And so what we saw is that the students actually have a very high perception of their own compassion, empathy, kindness, and caring. Certainly in the first year of medical school, they rate themselves very high in these domains, and relatively lower in terms of sadness, responding to pain in others with sadness and sorrow. And certainly we did some internal validation and we saw that things correlated very nicely as we would expect to. One little thing that's interesting here is the correlation between their levels of interest, curiosity, and their levels of compassion and caring. And so there is actually a literature about the interplay between cognition and affect. And those of us who could appreciate the brain is wetware. It's not software, it's not hardware, it's actually wetware. And there's an interplay between those parts of the nervous system. Emotional intelligence we define more narrowly to be involved in terms of the perception of affect in a person or in a dynamic, the perception of what is a normal response, right? You should be sad if something horrible happens, right? And also the recognition of aberrant emotion. It's really important in a clinical setting, such as the one where I am now, to recognize when the patient is not responding appropriately and be able to take action as necessary. That said, this is a review published in the BMJ from our British colleagues. It says, unfortunately, there is currently no operational definition of the superordinate construct of emotion skills in medicine. Very nicely said, but absolutely true. And a comprehensive model would be very useful, as well as guidance in terms of how to develop these qualities. Moving on to emotional resilience. Resilience is very important, and you'll see a little bit later, turns out to be very high in our students, and robustly so. And so emotional resilience includes that ability to kind of bounce back, to be flexible, to attend to self-care, to be calm and capable, and to sort of heal yourself after something terrible has happened. And obviously resilience is very important to your long-term capacity and success in clinical care. That said, we are somewhat challenged in the healthcare professions as to how to build emotional resilience. One program that I came across was at the Indiana University School of Medicine, where they had developed a sort of a values-based social environmental type program where people work together and collaborate and actually engage in ongoing reflective practice. So that's one possibility. Then emotional regulation, clearly important to how medicine works, right? Do you show up for work? Do you postpone those fun things? If everybody else is going on vacation and you're on call, of course you come to the hospital and take your call. Are you conscientious? Do you prioritize the needs of your patients above those of yourself? And this is something that we take for granted, but you're going to see later in the study it's something that we need to be mindful of. And frankly, as I've highlighted here, here's a beautiful article by Jack Coulihan. Today's culture of medicine is hostile to altruism, compassion, integrity, fidelity, and self-effacement. I think all of us have had the experience where the noble acts don't get recognized, don't get lauded or appreciated, and we need to be conscientious in that. And then finally, I'd like to point out Deb Roeder at Johns Hopkins, who has for many years looked at the nonverbal cues within communication, said, we found few studies that have investigated the role of emotional self-awareness in communication skill acquisition and the delivery of care, despite many intriguing questions. All right, so we went on to look at this, and I'm going to tell you a little bit how we tried to engage students in a discussion of social emotional development in the classroom and how we tried to then assess that. So I created a seminar course called Pain in the Humanities, and the curriculum is available as a 79-page document with supporting materials on MedEd portal. And if you need the information about it, I'm happy to send that to you. So we had sessions on drama, literature, fine arts, and philosophy. And we were endeavoring to engage students to understand and recognize different types of pain, to understand how cause and context and culture influence the meaning of pain, right? Anybody who's taking care of a patient with cancer knows that pain can have a very distinctive meaning, whether it's due to metastasis or due to a herniated disc. I mean, those are entirely different things. The fine arts, we wanted them to be able to recognize pain in others and think about those visual clues. This is, partially akin to some of the work that's been going on at Yale in physical diagnosis. And then philosophy, because it turns out, and I'm going to show you, that pain, healthcare-related values turn out to be very important to, an evaluator's sense of whether this person is going to be a great doctor. You have to believe in the relief of pain in order to really do a truly great job at it. So I hope, I forgot to mention that there might be some fine art images in here, but these are some of the materials that we use for the course. We, in our philosophy module, we compared Stoics to Epicureans to utilitarians, and had a lot of fun as the students kind of thought about the relief of pain and how that might be influenced by your philosophy. We had some wonderful experiences with students reenacting Samson and the pain and anguish that Samson had, who was blind. He was removed from his position of great honor, but he actually didn't have very much physical pain. And so kind of comparing and contrasting non-physical pain to psychic pain is kind of an interesting experience. And Doris Lessing, who received ultimately the Nobel Prize, I can't say enough about the vibrant quality of her childbirth narrative, where even people who haven't given birth read that narrative and they're intensely moved. So what we did as part of the seminar course is the students wrote essays, and we had, over the course of several years, we had well over 150 essays. We limited our study to those 100 or so essays that focused on either personal pain narratives or an analysis of a pain narrative in the literature. And we developed an instrument over a series of discussions. We developed, pilot tested, validated an instrument that actually looked at multiple dimensions here. And so I've abbreviated those. That includes a cognitive awareness of the pain, reflectiveness about the pain, the emotional strength, emotional awareness, emotional resilience, emotional regulation, and then the value, whether or not the student conveyed the importance of the value of relieving pain. This is just to show you some of the raw data. The students, the instrument had very good dynamic response properties. And this is showing you that the Cronbach's alphas were all very high in the very much acceptable level. We had multiple raters, and the instrument behaved very nicely. What we found then is that our students show very high levels of emotional resilience. I mean, these guys that got into Johns Hopkins Medical School, they are resilient, if nothing else. They also showed very high levels of emotional strength in their writing, but interestingly, relatively lower levels of emotional regulation and lower levels of reflective capacity. So I think it is possible from an essay to kind of try to gauge that. I will just say with a caveat, our working team, our study team, included a very highly motivated medical student named Tim Sutton. And Tim said, I know one of the guys that wrote this essay, and he just read your description of your learning objectives and then tailored his essay to get a great grade. I don't think he really believes this stuff. And so we do have to be cautious that sometimes people will give their very best face to us, and yet at the end of the day, what we all really want is something that will be durable and meaningful and stay with that person even when they're not being watched. And the question is, do you do the right thing when nobody's looking? And that is, I think, going to bring me to one of the fundamental challenges that we have right now in the area of non-cognitive skills relating to medical education broadly and pain education in particular, and that is that we don't yet have the perfect language. I've been trying to use the terminology social emotional development because I think it's a very good umbrella term. Here I'm showing some definitions. This is a slide I pulled together relatively quickly. But certainly attitudes is something that has long been in the literature. I mean, people talk about attitudes, misbeliefs. When you read about nursing literature, certainly if you've ever applied for a federal job, they talk about knowledge, skills, and attitudes. So attitudes are important, but we're going to talk on the next slide about where the limitations might be. Behavior has become very popular, and I certainly think that there's a lot of behavioralism that plays into the current enthusiasm for competencies and entrustable professional activities. That is very much a behavioralist framework, but we have to be mindful that there's behavior and there's internal experience, and then we have this organism that's going to continue on. And what is that organism going to do in 2 years? Are they still going to be a great doctor? Comportment, which I think certainly has a long tradition in the pain medicine community, and some of our best mentors demonstrate excellent comportment, but again, a little bit of a behavioralist flavor. Character. Character is almost like a third rail for some people. They feel like we shouldn't be getting that involved in our students' lives. But at the end of the day, I think all of us who feel really good about what we do as clinicians believe that we are acting from a place of the best character that we could possibly cultivate. So there are limitations, and we don't yet have a single best term to talk about the non-cognitive skills in medicine. But I think that some further thought is needed. I think that we definitely need to be attending to how we can develop these things in a way that's rewarding for teachers and learners, and how we can get people to the right place in medicine, because there are huge changes occurring in our society, right? All of us here today know that society is a moving target, right? We have so many changes, right? We're all bouncing all over the globe. We're connected to our electronic devices. We don't spend as much time talking to people face to face. The world is changing, and we need to be prepared to address that. Those of us who are involved in teaching residents, we feel, gosh, these residents, they're not the same as we were. Am I wrong? And then I wanted to talk a little bit about the components of cognitive expertise, being mindful of the time. As a neurologist, we kind of break it down into certain component parts, including your basic declarative knowledge. I'm always asking people, can you name the US president? Can you tell me who was president before that? We always have these tests of knowledge that we give to people as neurologists. But also, you need to think about their semantic skill, their information, their knowledge of and capacity for information gathering, their ability to construct a meaningful and useful illness narrative. That's actually a cognitive skill, right? Can you tell a story that makes sense and hang together? And your ability for diagnostic reasoning. All of these are sort of interrelated, but together contribute to true cognitive competence. So, operating in the cognitive domain brings me to how we look at content in the medical curriculum. So I wanted to bring people's attention to a reference that I'm very fond of, and that is called Curriculum Development for Pain Education, for Medical Education, a 6-step approach. And disclosure, this was written by some colleagues of mine at Hopkins, but I think it's a very rational approach. It's one of those kind of very straightforward processes, but you start with a problem identification. So we talked about the fact that there is lots of pain out there, right? And we're not doing a good job. Then you need to do a targeted needs assessment. And that was actually what drove us to do our pain survey. You then need to develop goals and objectives, think about educational strategies, implement, and go through the process of evaluation and feedback. And I'll show you some of how we did these parts. So needs assessment, lots of pain, lots of inappropriate pain care. Now this is where things get a little challenging. Task assessment. We clearly need to do a better job of pain education. How do the existing institutional structures support us in this? So one example is that the Liaison Committee for Medical Education, which is the accrediting board for medical schools, actually does not mention pain a single time in their accrediting document. Neither does the nursing school accrediting board. I will say that the pharmacy board requires representation of concepts of pain management, and the physical therapy board requires that students are educated about examination of pain. So we have work to do at this very high level, of what do the accrediting organizations require, But there's other things that are happening. I heard today that the Massachusetts board is requiring physicians to have pain CME. I know that's happening in Maryland. Certainly California has had it for a long time, leading the way. So I wanted to show you a little bit about how we implemented pain curriculum at Hopkins, and this has been presented in pain medicine. And we did endeavor to incorporate cognitive, affective, and reflective components, but I will give a note of caution. So just in terms of how we deliver content, so we had a mixture of delivery mechanisms, lecture, small group, team-based learning, which I'll be happy to talk about if there are questions. We had a pain laboratory where we actually had students do the cold presser test. I will say that the cold presser for our students was much more painful than the literature had led me to believe it would be. I thought it was going to be a 6 out of 10 experience. Our modal representation was closer to 7 or 8 out of 10. So the students had quite a bit of discomfort with that. We were able to demonstrate the active diffuse noxious inhibitory control for those pain experts in the audience. If students had a Band-Aid on and they took it off before the cold presser, it hurt more than if they had a Band-Aid on and took it off while they were still having pain from the cold presser. That cold presser pain overwhelmed the Band-Aid pain, which was admittedly not much, but there was a measurable DNIC effect. So we delivered a lot of content. We got them into small groups with pain mentors, with pain clinical mentors. We tried to get them into a team-based problem-solving environment. And what we found in terms of assessment is we wrote the test too hard. The average test score was lower than we would have liked. But what was interesting is we had another component of the test, which was actually where we took students and paired them, and they had to problem solve cases together. And that actually was a great thing because we had students talking to each other during their quiz, trying to communicate about pain and solve these problems. And that was a wonderful thing. Having students highly motivated to communicate about pain was, I just can't say enough good about that paired quiz-taking modality. And then we also had a 35-page reflective portfolio, which has subsequently been removed from the course because it was very unpopular with the students. We had students who said, I wrote essays to get into medical school. I don't want to write any more essays. But there were students who did work that was awesome and inspiring and so motivating to those of us who were instructors were so inspired by some of the work that we saw in the portfolios. So I will only say that there's a tremendous reservoir out there. What we need to do is figure out how to carry everybody along with that. All right, so we have a little bit of time left, and I'm going to mention just briefly some of the resources, some of the sort of big things that are out there that people need to know about in terms of if you're designing a curriculum, whether you're coming from medicine, nursing, pharmacy, there are some resources out there, and I want to sort of point out where the like, when you're out on a boat and there's a rock under the water, you want to know where that rock is. So I'm going to give a little map here. So ISP has put a lot of effort into creating updated pain curricula. These came out, I think, a year or two ago, and some of them are quite exceptional. So I want to give a kudo to the nursing curriculum, and they had shown here some of the task force members, but here's the statement. Every nurse should be able to assess and manage pain. Wouldn't it be wonderful if the doctors could say that too? Sorry, wouldn't that be wonderful? And so if you look at the curriculum for nursing, it is exceptional. And if you look at the curriculum for the interprofessional curriculum, it is exceptional and really an inspiring document. I don't have something good to say about the existing medicine curriculum. Here's a segment on the management of pain. And this is my concern. The section, I think, overly emphasizes neurostimulation, nerve blocks, surgical techniques by putting these things on par with things that we know need much higher uptake and utility. We need to spend a lot more time in medical school talking about the nuts and bolts, the basics of pain management. And if we could get a lot more of that basic pain management right, I think all of us are thinking that we won't need as many neurostimulators, we won't need as many nerve blocks, but we need to get it right at the primary care level. And this doesn't work as a primary care roadmap. And what is sorely needed right now, I think fellowship programs are robust, they're thriving, they know what they need to do, they know what they need to teach. It's a really tight-knit group of people. What we need is primary care to get this right, because that's where the trouble is. So ISP missed opportunity. At the same time, we were not really involved in the ISP effort. AAPM, the American Academy of Pain Medicine, decided to take a look at pain curriculum for medical students. And when we said medical students, we really meant that entry to licensure type level of training, which is an undifferentiated, right, potentially primary care person. We think, what do you need to know when you're an intern and you're practicing your general medical care? This is where I actually led the study, but I was not on the board at the time. I was thrilled with the outcome. What we did is we used a modified Delphi technique, a survey modality, where we administered these 225 learning objectives to the board members. We did it in 2 waves in order to get an adequate number of participants. And we then had them rate these 225 learning objectives from 0 to 4, and these are the top 5. Be able to distinguish acute and chronic pain. Know of the importance of an exam and diagnostic testing to obtain an accurate diagnosis. Know the definitions of addiction, tolerance, substance abuse, and dependence, including pseudo-addiction. Demonstrate knowledge of and promote compassionate care practices, and display empathetic responses to patients with pain as a primary complaint. I think this is a splendid outcome. I mean, this is really important. And I'd be more than happy to share the paper with anyone who's interested. These are the domains when we associated the learning objectives into topical domains. You can see that these were the raw scores. And the committee then, the medical education committee then came back together as a group, weighed the results of the study, and devised a list of 27 recommended topics. We did have to bring back in pediatric pain because the AAPM is really focused towards adult pain medicine care providers, both specialists and generalists. But we just sort of took that balance. Evidence-based medicine does require some additional work to give an appropriate interpretation. These are the topics that we used to do our pain survey study. I wanted to just mention briefly the core competencies, which I know that Scott Fishman has been here, so I'm not going to go over those in detail, but core competencies for the Interprofessional Consensus Summit. I think this is a very important project. The core competencies do actually align with the IASP topic areas, but I would also say that I believe that in addition to having the core competencies that are required within the interprofessional sphere, I think each of the professions has to get its house in order in terms of what are our profession-specific competencies and content and responsibilities within pain clinical care, right? So nurses need to know very specific things, physicians need to know very specific things, pharmacists need to know very specific things, and we all need to be held accountable for what is within our domain of expertise. All right, and I'm going to conclude. I have a couple extra slides in case people are interested about specific topics, so I'm glad that we have time for questions. And I'm going to conclude by saying that recent surveys indicate vast gaps in the state of pain education and the need for pain competence in clinical practice. The opportunities for positive change are enormous, and there's no shortage of compelling questions that need to be answered before we can declare success in preparing exceptionally qualified clinicians. And a well-developed curriculum will need to address the cognitive, skills-oriented, and social-emotional learning needs of clinical trainees. We know that multiple learning modalities and conscientious mentorship are requisite. Thank you.
Can you hear me all right? So I wanted to thank Beth very much for showing you really a very broad perspective on what's happening. And the fact is that she's been involved in every aspect that's important at the cutting edge. I'm going to use a prerogative, I guess, of the moderator to ask Beth that as a math major, she had mentioned that she was accustomed to thinking in models. And she did show you briefly a model that's a traditional model that links nociception, that is the function of nociceptive neurons, to the experience of pain. I wonder if you might chat for 2 or 3 minutes and then entertain some questions.
Thank you. Okay. So Dan and I, over the years, have had some conversations about the biopsychosocial model, and those of you who know him know that he's a huge enthusiast. I come from a sort of more laboratory-based neuroscience background and have for several years struggled with what's called the Lozier model, or the biopsychosocial model of pain. And so that's represented down here in the corner. It's usually kind of this onion skin model that starts with the event of nociception, goes on to perception, and then suffering, and then behavior. And it's always shown as kind of this ripples in a pond, expanding rings kind of phenomenon. And I was struggling with this because to me, it seems like there's a lot of times when pain doesn't do this. And so I came up with the following representation, which Dan actually pointed out ties back to Philip Lepay's concept of eudaimonia. Yes, sorry. My context for the prefix "eu" is eudaimonia, which is always a good idea. We'd like to see the expansion of happiness. So eudaimonia being the concept of normative pain processing, right? All of us know, and what I tell medical students is, the pain system is a lot like the immune system, right? We need it. But when it's overactive or when it's underactive, the organism comes into harm's way. So most of the time, the pain processing system is a faithful reporter of important environmental cues, right? If your kid stubs their toe, if your mother burns her finger, you need to know these things for the protection of the organism. So normally, there is a nociceptive event. It rises to the level of perception, and rightly so. It should mirror the nociceptive injury. And then you will have some suffering. You know, say you cut your finger when you're chopping vegetables and you happen to get lemon juice in that cut. It's going to hurt more, and you're going to be like, darn, that shouldn't have happened. So there will be some suffering, and there may be a behavior, right? I mean, for years, the dogma in the pain field is there's no pain behavior. But in fact, for acute pain, there's very often a behavior. Women in labor, they all scream, right? Except for, the very few. People who get their hand hit by a hammer, they all jump up and down and do this, right? Except for those tremendous stoics. But when you have a place where the organism is not in equilibrium, you can absolutely get a scenario where pain just amplifies at every step. And because I worked as a resident, I'm currently working with veterans, we see a population that has a lot of challenges. So it's not uncommon that a nociceptive event is amplified by fear and hypervigilance. And this can happen in any setting, right? But it often happens in a setting of trauma, right? We know that, for example, the opioid risk tool, right, which gives us a good gauge of how risky it is to prescribe opioids. One of the elements, certainly for females on the opioid risk tool, is, were you exposed to early life sexual abuse? I mean, it's a serious issue. So when you have fear and hypervigilance, you are at risk for heightened perception of pain. And then there are cognitive factors such as depressed mood, right? We all know of the prevalence of people with affective disorders in pain clinics. It's huge. And you can barely begin to unravel that chronic pain problem until you've addressed their depression, anxiety, their affective disorder. And then lastly, social factors such as poor social support, isolation, frustration, job loss. We all know secondary gain, right? You want the disability but not the work. Those things can very definitely magnify behavior. And so what I would say is that the drops in the pool, it depends on the state of the pool at the time. And I think that we all know that the biopsychosocial model is really what's the really most representative model. But we also know that, as Bach said, all models are wrong. It just depends on whether they're useful. So thank you. I'll take any questions. Okay, good. Well, thank you all. It was lovely to be here, and please send me an email if you want to chat.